My name is Dr. Larry Dean. I'm the director of the University of Washington Regional Heart Center. I'd like to welcome all of you to another University of Washington Regional Heart Center Grand Rounds. It's a distinct pleasure for me to be able to introduce Dr. Ed Verrier, who is the chief of the cardiothoracic division at the University of Washington School of Medicine, to discuss with us innovative surgical strategies for end-stage heart failure. Dr. Verrier.
Thank you and good morning. The evolution of cardiac surgery has changed dramatically over the last few years. Some of it has to do with the tremendous innovation and technology that's occurred through our cardiology colleagues. The introduction of percutaneous transluminal angioplasty, stents, radiation have made the patient populations that were classically approached by surgical techniques be delayed. In that delay, we have seen a number of patients who now present with not only coronary artery disease or ischemic symptoms, but very advanced disease where there's impairment of their ventricular function. So that the patients that tend to be referred for surgery these days are sicker with more impaired ventricular function. That's given the stimulus for the surgeons to look a little bit more critically at some of the issues related to heart failure and whether or not we can complement some of the outstanding contributions made by our medical colleagues by understanding surgically whether there are some anatomic and physiological principles that we could understand and apply to the treatment of advanced cardiac disease. This is a very significant problem. As you can see by this slide, right now almost 5 million Americans have congestive heart failure. There are almost 1 million hospitalizations every year for heart failure, and this is only going to increase as our population ages and their heart disease advances. The cost is staggering, $22 million a year, and the overall prognosis once somebody develops heart failure is extremely guarded. So this is obviously an area where both the innovative technology as well as increased medical management and possibly surgical improvements can help us. Now, the classic approaches that are done by our medical colleagues and done extraordinarily well include lifestyle changes, diuretics, the introduction of vasodilators about 20 years ago to reduce the resistance the heart must squeeze against, use of digoxin, ACE inhibitors, another variation of a vasodilator, and now some new beta blockers which seem to help medical remodeling of the ventricle have given a whole different set of approaches to the medical management. Having said that, the prognosis continues to remain poor. What I'd like to do today is talk about some areas where surgery has an impact in the treatment of advanced heart failure. And I'm going to put a little bit of an emphasis on ischemic cardiomyopathy just as an introduction. We'll talk a little bit about mitral valve disease. We'll talk very little about cardiomyoplasty as a technique. I'd like to review some of the newer data related to mechanical circulatory support. This is an area that's got some recent press when patients were treated with a totally implantable heart. And I'd like to put quite a bit of emphasis on surgical remodeling and what we understand about the anatomy and physiology of the main pumping chamber or the left ventricle. So right now, I'd just like briefly to talk about ischemic cardiomyopathy. So what does that mean? That means that if there's a lack of blood supply to the heart muscle doesn't function. It doesn't receive oxygen, it doesn't receive nutrients, and therefore the metabolic activity of that muscle has to change. When the metabolic activity changes and it reduces, the ability for that heart to squeeze and to generate power to distribute blood throughout the body becomes diminished. Therefore, if we're going to look at what we call ischemic cardiomyopathy, in order for surgery to be a therapy for heart failure, we would need to recover some of that function. So by bringing more blood supply, more nutrients to the myocardium, we would expect that there'd be some recovery of function. This entity has been called hibernating myocardium, i.e., the heart itself sets its metabolic activity lower than normal, doesn't squeeze as well, but is able to exist in somewhat of a hibernating form. The thought then is that if you bring more blood supply to that heart muscle, these sarcomeres, these cardiac myocardial fibers, will now be able to work better, shorten more efficiently, and generate more power and therefore blood flow. The key then for us in the treatment of surgical treatment of heart failure is to determine whether or not the myocardium is hibernating. And there have been a number of studies that have shown that by the use of nuclear imaging, as well as stress echocardiography, the use of viability scanning by labeling molecules that are essential to determine whether the heart muscle is alive or scarred, and whether or not it maintains its thickness, are all indicators of whether or not that myocardium may be hibernating. By using these types of studies, we can get these kinds of results. This was a study that was done about 5 years ago that showed a markedly enlarged volume, reduced ventricular function. Your normal ejection fraction is 60%. In heart failure, when it gets reduced in the 20 to 25 range, it can lead to heart failure. So that an ejection fraction of 23% is significantly reduced. Cardiac index is reduced. Pulmonary pressures are secondarily elevated. The pressures on the left side of the heart, which are normally 2 to 8, are now elevated to 16. But with a relatively low operative mortality of 2%, we've been able to increase the ejection fraction, or the percentage of squeezing, almost double, from 23 to 39%. And these studies have been shown not only to be able to see this improvement, but to see, based on the type of scanning, whether or not we have a good positive predictive value or negative predictive value by using various modalities of imaging, like a PET scan or a dobutamine stress echo, to determine whether or not we're going to get recovery. And in fact, there have even been studies that shown that you can, by looking at this mismatch, determine or predict how much return of function that you may receive. Now, this is not feasible in all patients, but by using discriminately these types of preoperative testings and then performing good, effective total surgical revascularization, we can use surgery and interventional radiology, if we can get the type of complete revascularization, to see improvement in ventricular function as a primary therapy for heart failure, not necessarily angina, which is what we normally think of in terms of either interventional cardiology approaches to atherosclerotic coronary disease or surgical approaches. Where do we go from here? Well, I'm going to skip valvular for the minute and use that a little bit later. But what I'd like to talk just briefly is mechanical circulatory support, only because it's received a lot of press. And there's no question that the use of ventricular assist devices is important. So this past Monday, we had a 49-year-old gentleman who presented to the University of Washington from an outside hospital, 12 hours into a massive anterior wall myocardial infarction. He was in cardiogenic shock, which means he couldn't generate an adequate blood pressure. We received him. He was young. He was otherwise what we thought had been alert, even though he was in shock. We brought him to the operating room, did 2 bypass grafts, and inserted a left ventricular assist device. And it looked like this. It's called the HeartMate. He's now awake in the intensive care unit, recovering, and we're using him most likely as a bridge to transplant. He had so much injury, he totally occluded his left main coronary artery, that we doubt if it will all come back, although we'll monitor him closely over the next month or two, but we've already in the process of listing him for a transplant. Well, the question also comes up is that if it's a bridge to transplant, is it a destination? Do people do better with an assist device than being in profound heart failure? We don't know that completely, although I'll give you some insights. First of all, this is the left ventricular assist device that only bridges one ventricle. We now have in trials, as you've known, a total artificial heart that has been put in about 8 patients to date. The early results are not known. It's only being done in 5 centers in the United States. It will take a few years to determine whether or not the total artificial heart is a viable alternative. But it's definitely better by technological advances than it was when it was originally introduced almost 20 years ago. What is interesting is what's called the Rematch Trial. And this is a trial that was designed about 4 years ago. The University of Washington was one of the primary investigative sites. And the Rematch Trial stands for Randomized Evaluation of Mechanical Assistance for the Treatment of Congestive Heart Failure. Took 129 patients, randomized them to medical therapy or this assist device. Now, the medical therapy was very significant heart failure, not the ones that can be easily managed by medical therapy. The overall results were that there were a 48% reduction in all cause of death in the left ventricular assist device group. The 1-year survival was almost doubled in the VAD group, and the 2-year survival was a difference between 8% and 23%. This was the first randomized prospective trial showing that there may be a benefit in using left ventricular assist devices for patients with profound heart failure that may not be candidates for transplant. Now, we can argue whether or not you'd want to have this assist device in for the rest of your life, but in those patients, the lifestyle changes were also thought to be improved. So this may lead us to have greater interest in the use of assist devices in the treatment of profound heart failure. This future will change also because already we know that there are a number of assist devices that are going to be smaller, easier to insert, and may have the same type of physiological benefit. I'd like now to spend some time on surgical remodeling. And this is an important topic because for the first time in about 25 years, the National Institutes of Health are funding a multi-million-dollar trial to look at whether or not surgical therapy may have some benefit in heart failure patients. And it's called the STITCH trial, and I'll get to that at the end. But I'd like to lay a foundation for understanding of why we believe the STITCH trial may be important. The key to the STITCH trial is trying to understand how the heart works. One of the things that we've known for many, many years, or many centuries, is that if you look at individual heart cells, they only contract or shorten about 15% each time they move. Well, when you then put them together into some type of a heart anatomy, all of a sudden they have the ability to generate 60% ejection fraction, which means that they empty the heart 60% of its volume every time. Well, how do you get this little tiny movement of an individual cell to equate into this very powerful pump? Well, it was first noted all the way back into the 17th century that the heart was shaped in this cone and that there was some type of an apical vortex with external fibers that moved inward to give this very unique torque to the contraction of the heart muscle. It was around that time described as squeezing of the blood out of the ventricle. It was also noted embryologically that in a snake, the normal cardiovascular tube was straight. But in order to evolve a heart, it had to loop back on itself, form a figure of 8, then ultimately twist to give this conical shape. And this was first noted back in 1891 by Krull as the figure of 8 fiber continuum, and ultimately developed them into what was further described in the 1957 as the helical band structure. And I'm going to spend just a little bit of time on this because the surgical approaches to the failing ventricle may be the reconstitution of this helical band structure as a theoretical and experimental or hypothesis to determine whether or not by reconfiguring the failing heart into this conformation, we may have patients live longer, feel better, take less medicines, and have a good surgical alternative. Well, what is it? I need to spend just a little bit of time on this slide. And this is that figure of 8 that we talked about. If you take the heart and you unloop it, and you start unlooping it, ultimately you get to the single tube, like a snake's heart. So it starts to form back on itself, and you ultimately see a figure of 8 and this twisting, ultimately leading to the two ends of the loop being the aorta and pulmonary artery. When you start to unravel the heart, you can see that there is a very main, what's called basilar band. And this is horizontally oriented and at the base of the heart. As you further look at the heart, once this band, there's a different orientation of the fibers in more vertical form, or what's called the apical conformation. So if you look at, in this final one down here where we have the tricuspid and mitral, they're part of the basilar segments, whereas the left ventricle and right ventricle, the more apical form the latter parts of the ventricle called the apical loop. So we have two loops, the basilar loop and the apical loop. So these are kind of important concepts. When we then look at the bands and we then try to take this anatomic conformation and look at it physiologically, we see a couple of things. When contraction is initiated, the first loop, the basal loop, contracts, making the ventricle narrowed. It's then followed by this apical or descending loop as the electrical pattern automates the ventricular muscle. And we then see shortening of the ventricle. And the final conformational change is lengthening when once again we see the ascending apical loop contracts, giving this pattern of basilar narrowing, shortening, and elongation in each heart cycle. Obviously, there's a different orientation of the basilar loop and the apical loop, as we've already noted. Well, what happens in heart failure? It's very clear that in almost all forms of heart failure, whether or not it's ischemic, a big myocardial infarction like the gentleman who presented this past weekend, valvular, where the heart dilates, the mitral valve frequently regurgitates, and we have this big ventricle emerge, or even in dilated cardiomyopathy, idiopathic, we don't know why, or viral, the heart changes its conformation from this conical, helical shape into a globular, looks more like a basketball. And it's fairly consistent in all of these forms of heart failure. If you then look at what the changes are in the cardiomyopathies, if you look at that normal basilar and apical loops on both of them, you can see in the normal heart, there's almost an orthogonal relationship between the basilar loop and the apical loop. But in the dilated cardiomyopathy, you change this contraction pattern, you change these angles, and you become much more inefficient in terms of your contractility. In contrast, in the apical loop, once again, as it contracts in that shortening and lengthening axis, all of a sudden it compresses in the globular heart and you lose your efficiency. So what does that equate to? That equates to the fact that if you have this circumferential enlarged heart, even with the normal 15% squeezing ability, all of a sudden your ejection fraction in the circumferential goes down to 30%, and in a type of spiral helical, you end up with a normal ejection fraction of 60%. You can imagine that if you then have problems with the muscles themselves squeezing because they've changed from muscle to scar, it even accentuates this more significantly. So this is the foundation that led the surgeons to look at and the cardiologists to say, okay, well, what could we do to improve this? And the primary aim of surgery would be to improve the function through the alteration of structure. To this end, a thorough understanding of structure and function is imperative, a little bit of the basis of which I've talked about. Now, how does this equate into surgery? And although I've used this under ischemic cardiomyopathy, you could change this to potentially valvular, or you could change this to dilated idiopathic cardiomyopathy. Vincent Dorr is a surgeon in Europe who a number of years ago had this concept that we could change the function, change the structure of the left ventricle and end up with improved function. And he developed a procedure called the Dorr procedure, whereas he looked, in this case in ischemic, where there was this huge apical scar from somebody who had a left anterior infarction and said, okay, if we take this globular structure and we open it and we lose the apex, when you look in, there's sort of a ridge of normal functioning ventricle. If we then take a circular patch and we put the patch across this, narrowing that ventricle, we'll change the conformation of this ventricle from that globular structure back into a somewhat more normal helical or conical structure. And you can see that this is another schematic of taking out the scar, if there's arrhythmias, taking out potential sources of arrhythmias, looking at the neck inside this area, putting on a patch. By putting on a patch, taking this globular function and now making it a narrow apical function. This is the final schematic of what it looks like when you complete the Dorr procedure. You put the patch in, you lay the muscles, the old scar on the outside, and this is what the Dorr procedure looks like. Well, what happens then is that you take this remodeled sphere, and whether or not it's ischemic or dilated, you once again attempt to change particularly the apical bands into a more apical structure. Well, what are his results, and what is the foundation for us to go ahead? Well, he initially reported in 1995 171 patients. 166 of them were in the anterior location, which is the easier one for the surgical to approach. Time from infarction, 43 months. Heart classification, over 50% of them were in class 3 or class 4. Ejection fractions were under 40% in 75. This was his original series. Arrhythmias, CABG, 96%, since they had mostly ischemic. And interestingly and predictably, ejection fraction increased from 36 to 46%. Left ventricular and diastolic volume would be reduced. End systolic volume would be reduced. New York Heart Association classification would be improved. And he noted the greatest benefits were in those patients with severe left ventricular dysfunction, more arrhythmias, and larger left ventricular volumes. He then went on and did a second study and looked at the difference between a dyskinetic scar. So when the heart squeezes, instead of that scar remaining stable, it actually bulges paradoxically. He compared just the akinetic from the dyskinetic scar. Retrospective, 100 patients, about 50-50 in both. In this group, all of the ejection fractions were under 30%. 98% of them had associated coronary bypass surgery. Some of them had a mitral valve repair. Some of them had therapy for their arrhythmias. And once again, relatively low mortalities in this high group of patients. Preoperative ejection fractions, 23. Improvements from 31 and 41%. And the operation appeared to be durable, at least for 3 years. So that was a very important improvement, because in other operations, particularly the Batista procedure, which is a different one that was used for cardiomyopathy in other countries, the durability didn't seem to exist, where with the Dorr procedure, it seemed to exist a little bit more important. So this led to the surgeons, cardiologists, and anesthesiologists coming together and saying, is this a reasonable approach to patients with heart failure? So the STITCH trial, surgical treatment of ischemic IC heart failure, multi-center, multinational, prospective randomized trial, patients with congestive heart failure and coronary disease amenable to surgical therapy. And the thought is that if you look at the revascularization hypothesis, 2,000 patients, heart failure, ejection fractions under 35%, volume indexes greater than 60 mLs, that in those patients treated with medical therapy, their survival would be significantly reduced out to 6 years with medical therapy alone, and that it would be improved with revascularization. We have other data showing that surgical revascularization will improve these patients. And then, of course, if you add on top of it this volume reduction surgery, that you'll see an even greater improvement. Remember, the medical therapy would be below this in terms of their overall survival. So this is the hypothesis of the STITCH trial. It is now in the IRB approval at a number of institutions, including the University of Washington, and we hope to enroll the first patients in this trial coming in approximately June. So the trial is designed coronary disease, low ejection fractions, heart failure. They have to have coronary disease. If they have left main disease and coronary disease, then they can either go into the surgical side or the medical side. If they have left main disease, they all go to a surgical side because we know that the prognosis of medical therapy with left main disease is terrible. So those all go to the surgical side. But once again, you can see if they have 3-vessel coronary disease, heart failure, they can be randomized to the medical side. There'll be 800 patients in there, 800 with CABG in that. If they're a candidate for volume reduction surgery, some of them will be managed with medicine, CABG, or CABG plus volume reduction surgery. If they have left main coronary disease, they'll only go to the surgical side and either be randomized to CABG alone or CABG with volume reduction surgery. So we believe this is a very significant, exciting trial looking at whether or not we can improve this monstrous group of patients with heart failure by more aggressive surgical approaches to coronary disease. In conclusion, this is a new era that we're entering related to patients with advanced coronary and valvular heart disease. How do we improve their survival and improve their lifestyle? Well, we believe that there are some approaches to it that combine this multidisciplinary team. Can't be done without outstanding anesthesia, can't be done without outstanding cardiology, and it can't be done without outstanding surgery. It's a multidisciplinary team. Second of all, the preoperative assessment, as we've noted, is critical. Do they have the scar? Do they have the type of reversible myocardial perfusion defects that could be improved with revascularization? So having careful and experienced preoperative assessment is essential. In order to take care of these patients, their perioperative care must be meticulous. They have very small margins of error to end up with very big mistakes and poor outcomes. So meticulous perioperative care, in my opinion, is essential. Not only do you intervene in one moment, but this is clearly a group of patients that you must follow longitudinally because they have multiple other associated problems. They frequently will have the diabetes, hypertension, and other cardiovascular risk factors. So the longitudinal management of these patients postoperatively is essentially. In well-selected patients, I think that you can get excellent results and improve heart failure. Make it so that their lifestyle's better, they take less medicines, they're functionally improved, and they're very, very happy having had this type of approach. One caveat is that obviously any type of mechanical assistance or very complicated surgery is expensive, and so the costs are going to need to be assessed. Thank you for the opportunity to present this morning.